So here the coil's coming out of in the aneurysm right now. You have to go very slowly because you can rupture the aneurysm when the coils come out. See the coil achieving that configuration? It's staying, they're three-dimensional coils. It's unwinding, unwinding. The goal is to fill the dome of the aneurysm up with these, and it blocks blood flow from going in. So now the coil is coming back towards the neck, and that's a little bit of a problem because it can block the parent arteries. But I still think he's in good position right now.
People are wondering, how do they guide the catheter through the body to get to there?
So there's a femoral sheath down in the femoral artery in the groin that starts the access. And then we put a second catheter, this is the tip of it, all the way from the femoral artery up into the internal carotid artery in the neck. We can see the arteries because we can inject contrast and we get a road map. See, this is like a road map view. We can make an angiogram like this, and then we can subtract it and make a road map, which is the white, and leave that up there. So now we have basically a map. And then we can pass a wire along with a microcatheter through the large catheter, and then we can follow the vessels up simply by turning it and twisting it and manipulating the wire, and then you can advance the wire into the catheters. Here you can see the coils alone without the road map. And now Dr. Ortiz just did a run. He's just injecting contrast to see how things look. But basically you just guide the wire in, and then you guide the microcatheter, you push over the wire. These are all engineered, it's an incredible amount of engineering that does this. So now he just did a run to check the flow. So there's the femoral access down here. So this is the base of the patient's head is up here. There's the right femoral area, and here's the left. That's the access point. And this is the tip of the catheter as it comes out. And you can see when Dr. Ortiz approaches the table, he'll use, this is the access down here in the lower right. For some reason, the picture's breaking up. So he already put one coil in. Now he's trying to select a second coil with the other catheter. Now you'll see what they do is the coiling an aneurysm is like putting a ship in a bottle. The ship comes in flat, and then when you put the ship through the neck, it's flat. When you pull the string, that the sails go up. The coils work the same way. Here he's doing another road map. Now it's a new road map view that shows the coils in two different views. This is an AP view. This is a lateral view. Now you'll see he's going to advance the coil down here. This is the tip. The coil comes in a little sheath. And so he's going to put the coil into the, let me see if I can move the camera down on his hands. You can see his hands there. So now he's going to put the coil. He's advancing the coil in the microcatheters right here. So he's advancing the coil into the microcatheter from below by pushing on this little pusher inside the sheath that pushes the coil out. So he's gently pushing on the pusher wire, and now he's going to advance. And here comes the coil up top. So now he's pushing from below, but he's pushing that wire up, and this is the tip of the coil as it's about to emerge from the catheter. So the tip of the catheter is in the aneurysm. He's going to push, 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 push. It's staying in the catheter, and now it's going to emerge from the tip and take on its three-dimensional conformation. there's the tip of the coil. It's sort of in the parent artery, so that's no good. See how the coil is coming back? That's not a good thing. So he's going to have to pull the coil back, I would think. See, he's withdrawing the coil now. Obviously, there's a lot of finesse here because these aneurysms are very, very thin. If you push too hard, you can rupture the aneurysm. And if there are any questions, Josh, I'm happy to answer them.
You guys doing this in real time?
Yeah, this is really happening right now. Live aneurysm coiling.
Absolutely incredible.
You can see he's having a little trouble getting that second coil going into the dome. And it keeps coming out of the, just almost too much resistance.
You know, you probably talked about this already, but just for the students to understand, you know, this was a surgical disease, an open surgical disease. This was a brain surgery that people got for, you know, years and years and years. And now through a needle hole in your groin, right, 4 feet away, a surgeon is able to, you know, cure your aneurysm. It's kind of incredible.
And actually, we're going through the radial artery now in the arm. A lot of people are doing that.
Yeah.
You can see how that the tip of the catheter is kind of waving around in there. These are very, very, I mean, it's hard to understand. The aneurysm itself is about 6 millimeters, 7 millimeters in size. Can give you an idea of how small this actually is. He's definitely having trouble getting the other coil in. The coil keeps coming out into the parent artery, which is not ideal. Obviously, the key is keeping the coils in the dome or the fundus of the aneurysm. If the coils come out into the parent artery, you can cause a stroke if you leave them there. Right now, the patient we usually put them on a little bit of blood thinner to prevent clot from forming inside the arteries.
Will he use a balloon, Dr. Langer, to kind of push coil in?
Nope. So we'll come back to it. How's that? We want to sit here and watch this, or we should come back to it?
You keep it running in the background.
What's that? What are people saying?
They're saying watch it. Leave it running, they said.
Okay.
They want to know if Bookvar is still joining.
He canceled on me.
What?
So now we'll probably see everybody leave, which is fine.
Someone asked, you know, how they get the catheter up from the groin or from the radial artery.
Yeah, so you know, there's the vessels themselves, the guide. As long as you can see the arteries, you can guide a catheter because you can create twists and turns in a wire and make turns in the arteries. So as long as you can create these roadmap views of the arteries like this, you can use a wire to sort of make these turns just by bending it or shaping it and then turning with your fingers. Sometimes it takes a little creativity, especially as the vessels get smaller. But basically, you know, when you see the artery, you can actually guide the wire and the catheter into different positions and gradually turn it into the direction where you want it. And that's how it works. The key is you need support. If the wire's if the tip of the catheter in here is very, very flimsy, so that's why you have to have larger catheters down low. We sort of stack the support on the way up because you need some firm, something to press against. If it's really flimsy and you're pushing all the way down from the groin, you're not going to have anything to push against. So we put a larger guide catheter up first. That gives you some support down here. And then we pass the microcatheter up inside.
Have you played around with the robot yet for these?
I haven't. It's you know, still a little preliminary, and it's using it primarily for stroke, not for
Yeah.
coiling aneurysms yet.
Someone just asked if physical strength is important in the field of neurosurgery. I mean, as you and I are extremely strong. And
We are
yeah.
really strong.
Wouldn't know the alternative really.
No, I think the only thing you need strength for is passing a shunt passer. I just strained my bicep putting a shunt passer in his.
I had my woman the other day was very doughy, and so mine passed
That's the
like
worst.
butter. Great. It was incredible.
So you can see he's trying to push that coil out again. He's really having trouble. You can see he keeps pushing the coil and pulling it back, pushing the coil, pulling it back.
People are asking if the coils can rupture the aneurysm or the vessels.
They can rupture the aneurysm. That happens. That's why you have to kind of know when to stop pushing.
People are also wondering, what would you do if that happened?
You just keep coiling. You know, basically, if the aneurysm, you keep pushing the coils, will eventually cause the aneurysm to clot. We also can lower the blood pressure. If the patient's on blood thinners, we give protamine, which reverses the effects of heparin. Luckily, that happens. But if aneurysms rupture, these are the ones that rupture small anterior communicating artery aneurysms. This is an aneurysm of the anterior communicating artery. It's a artery that connects the left and the right anterior cerebral artery. And that's exactly what this is. So this isn't too small. Small anterior communicating arteries have been shown to have the highest risk of intraoperative rupture. This is still sort of a moderately sized one. Sometimes the reason with the smaller the aneurysm, the less room there is for the coil to open, and so they rupture more frequently. Rafa's super patient though. Like, you know, I do both open and endovascular surgery. If I have trouble like this, I just stop and operate on it. Rafa he'll go at this for hours. He's like a freaking, he's so stubborn. But he's doing that's why he's so good.
Someone asked, can coils move out of place?
He got it in.
Incredible.
I don't know if he's going to get any more. And this little loop right there is a little bit close, but I think he's okay. Let's see what he's doing with his hands down below. So here you see this is the setup. He has basically a guide catheter here, and there are two microcatheters coming out because he's using two separate microcatheters to coil the aneurysm. He has his COVID face shield on. So here's the microcatheters come in these like sleeves, and he's going to advance the sleeve into the bigger, the coil comes in a sleeve. He's advancing it into the base of the microcatheter here, and then he's just going to push on the wire. It's like, basically it's like a tube, and the coil's inside the tube, and then the wire is the pusher wire behind it. You sort of push the coil up into the aneurysm.
I know you've probably talked about this before, but someone was wondering, when wouldn't you be able to use this technique?
If the aneurysm neck is too wide or it incorporates the origin of some of the arteries, the coils either come out too easily or they can block the entry of the normal arteries, and that can cause a stroke. So when you have a wide necked aneurysm or an aneurysm that incorporates the origins of these vessels, it becomes hard to do. There are devices like stents and things we're starting to use, that we use also, that protect the origins of arteries. So the technology is getting better and better every year. Like, the future of open vascular surgery is very grim. Plus, there are more and more people with catheters now. You know, a lot of times there isn't even somebody who's capable of clipping an aneurysm in your community. And so that they just do the best they can with because it takes a little bit longer to learn how to clip aneurysms. It's more of an effort, and it takes more time and effort, and there aren't as many cases to clip anymore. So more and more aneurysms are getting coiled or stent coiled, or there are things called flow diverters or all sorts of different devices. Here again, you can see the coil continues to sort of come out of the aneurysm into the parent artery again.
People are wondering, is there something holding the coil in place once you leave it there, and does it stay there forever?
It stays there forever. Here's a different view. So now he's advancing. You can see the catheter wanding around inside the aneurysm. I think he has a better coil position now. With the other view, yeah. So it's sort of hold now that coil's coming out again. So he pulled it back.
People are wondering what exactly the coil does for the aneurysm, that it like removes it, and like how does it work?
It fills it up from the inside. It just, blood goes in without the coils. When you put metal inside the aneurysm, it fills it up, and so less blood can get in, and eventually there's enough coils in it that it clots off. It just creates it disturbs the flow inside the aneurysm, and you start to get clot. And the coil mass essentially replaces the blood with a kind of thrombotic material. So then it starts to block more and more blood from getting in, and eventually the aneurysm is just protected. It just takes the pressure off the dome, basically. He still has a little tail of coil here sticking out. He has a lot of coil left. You can see that's how much more coil he has to put in. He's definitely still advancing it. Let's look at the other view. So there's basically an AP view and a lateral view. We can see all four views here. So here's his hands. There's one view. Here's the other view. Here's the static angiogram. You can see how he's pushing with his right hand. He's just gently advancing the coil. Getting closer now. He's advancing the last little bit here. You see it's getting a fair amount of resistance. This is the scary part. I mean, the more you push, the higher the risk of a rupture. That's the back end of the coil going in. Oh, he pulled it back again. See how he's watching very carefully. He's just gently pushing with his fingers. His hands are getting tight. You see that he was just it was a little stress in his wrist. So he was like relieving the pressure on his wrists. See his eyes going back and forth. He's looking at the screens here. Left and right screen are these two screens. So he watches both views. He's not happy. Oh, he got it in. It's in. See, it's all the way in now. There's no tail anymore. That's one view. Here's the other view. So you have two here, now he's going to do a run. Now he's going to inject, contrast. And now you see all the vessels filling. It's I think it looks okay.
People are wondering what kind of metal the coil is made of.
Platinum. I'm going to call up there and speak to him. Hey, is Rafa in there?
Hold on a minute, please.
Raf? You doing a 3D? You doing a 3D?
Hello?
Can Rafa talk?
Hold on a minute. We're going to put you on speakerphone.
Okay.
343365.
Trying to get him on the phone.
Someone is wondering what the timer is on the screen.
Sometimes we time things. Not in this case, we won't.
Let's give a bonus of 3,000 separate, 3,000, 3,000, and start a group of 1,000 per hour. Give us 1,000 an hour. Right? And then come here.
Hey, can I talk to Rafa, please?
Yeah, 1 second.
See that he just pulling the shunt. That's the pusher. He just pulled it out of the catheter after he detached the coil. So now he's committed. Like once you detach, you can't get it back. If you leave it attached, you can pull the coil out.
Dr. Lango hit it in the middle of coil.
Yeah, I'm watching. I just had a question about the right anterior cerebral. That's all.
Okay, I just put you on. Wait.
Just I'll wait. I'll wait. Hi. Hi.
What's happening?
No, is that right ACA washing out from the other side, or is that from the coil, you think?
So he has a really
Okay, so that's not from the coil. Is what I'm care about. Okay, I'm watching. All right, go ahead. Bye-bye. So he's putting another coil in now. So this is the third coil. So what he's done is all you're seeing is everything is subtracted except the new coil. So the old coils we can actually remove from the image. So they're almost like invisible. Anything black is new to the screen. So you can actually see inside the aneurysm where the new coil is going. And what he's going to do is he wants to make sure this new coil stays inside the bounds of the old one. In a minute, this little end tip crosses that marker, he knows he's all the way in. He's pushing a little bit more. Push, 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 push. Now he's crossing the marker, so he knows that tells you the coil's all the way out of the tip of the catheter. Now he's going to do a run. There's the coil frame. Now he's going to inject with his hand. Here's the contrast coming up. It looks very good. Very good. See, the whole aneurysm is filled with coils. That's the third coil in there. I think he's probably going to stop after this. At least I would. So now he's going to take the, I think he's going to be done now. He's probably going to take the catheters out of the aneurysm. That's the detachment device. It's a little electrical device that you activate, and it detaches the pusher from the tip of the coil, a little electrical. So it detaches so you can remove the pusher from the tip of the coil. If you don't detach, you can always pull the coil back and forth. Once you have the coil where you want it, then you put that little electrical cable on. Now he can take the, you see he's taking the tip out. Keeps his hands moist, because if your hands get dry, it sticks to the catheter and the wire. I think he wants to put one more coil in.
Okay.
So he's pushing the coil in again. Frank Moore. Hackinson. Or Pat. Yeah, I'm on the brain tumors. Did you get into the other? I'll fix it. So here you go. She's putting this last coil, and this is the marker again. Pushing, 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 pushing. And now it's in. You said a little bit further. It's crossing the marker. That's good. Gonna do another run. See, the coil's really nicely filled. It looks great. I think he's going to put more in.
way, please obey.
He's waiting. He's probably loading up another coil now. Here comes a coil. Here it comes, here it comes, here it comes. Now it's coming out of the tip of the catheter. He's pushing it, he's pushing it. Once you get like a nice frame, as long as the catheter is within the frame, it kind of holds the aneurysms in. You need to get coils near the edge of the neck, and that prevents, just by taking up space, the coils get wrapped around each other like a ball of yarn, and it prevents the coils from coming out. The tighter amount of coils you get, the more likely you are to obliterate the aneurysm completely, and the less likely it is to come back or re-rupture.
People are wondering if you ever have issues with the computer during it, and what would happen if the computer went down.
Yeah, we've had that problem. Sometimes you have to, it's all software, so we have to restart the machine. It's very dangerous. When that happens, you just stop everything and don't do anything. I mean, there's a huge computer that runs this thing. That looks great. See, there's no more filling. There's almost no filling of the aneurysm anymore. I was worried. See this right here? There's like a little, it looks like there's not as much contrast in this artery as this one. Sometimes the coil blocks the entrance, that could slow flow. It's basically slows the flow here, but this is actually washout from the other side. The right carotid is filling this arterioles. You're not seeing it. It's over here, but the right internal carotid connects to that complex. So because blood is filling that vessel, it doesn't have contrast in it, you get that washout appearance in the artery. So I was asking Rafa before. So now he just took the catheter out. Took the pusher out, and now he may be done. Let's see. Look at his hands. Yeah, he's done. So he's going to start taking the catheters out, I think. He's advancing a little wire up there. The wire, you just push the wire just to the edge of the catheter, just to make sure that the coil is completely out of the tip of the catheter. Then you can pull the catheter out. Here's the wire. Now he's just going to push the wire just into the aneurysm, because sometimes the very tip of the coil can be stuck in the tip of the catheter. So he's just pushing, and he's going to pull the catheter out of the aneurysm. See how it's straightening out? Watch. See how he's pulling, he's pulling, he's pulling, he's pulling. It's all straightening it out, and then you'll see the tip of the tip will come out. Breaking up for some reason. Getting some tension on it. It's like a rubber band. Pulling down, he's pulling down. It's out. There's the tip of the catheter. And he's pulling that all the way back down to the groin. Let's look at his hands. So he pulled that one out. This one's out. Now he has to take the other one out. So there's the tip of this is the tip of the other microcatheter. He's just wetting his hands a little bit. So now again, he's putting the wire in. It's the thin wire. And again, to make sure the catheter is totally detached from the coil inside the aneurysm. He's advancing, advancing, advancing. So he's going to advance that wire up again. You'll see the wire come up. Here comes the wire. And again, just gently pushing the wire just beyond the tip of the catheter, and then pulling the whole thing out. So now he's straining the catheter again. You can see the loops unwinding. These are just within the larger arteries, so you have to pull out the redundancy of the catheter so that you get the energy into it. Pulling, 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 pulling. Up, it's out. And now he just wants to make sure that none of the coils moved. Everything looks good. He's going to do a final run. That's the eye socket right there. The base of the skull. These are all the this is frontal sinus. Left eye socket, right eye socket here. So now he's going to do the final angiogram. See, you can see the other side filling, flash filling. That was the right side filling because the anterior communicating artery, which is right here where the aneurysm is coming from, communicates between the left and the right carotid circulation. So that right there is actually the right anterior cerebral coming from the right carotid. It's like a T. You have the left anterior cerebral here, ACOM, and then that's the other side. And that's why you're getting washout in this artery, because once this flows through, now you get non-contrast blood washing up into this right anterior cerebral artery there. Now he's going to do a full non-magnified view. There's the whole head. You can see the size of the aneurysm, how small it is. Here's the whole brain filling. Looks great. And that's all the veins. So you fill the arteries first, then capillaries and the veins. So the veins fill at the end. So arterial phase, here the arteries are filling. More arteries are filling. Now capillaries, looks like a blush. And then the veins fill at the end. So there's the internal carotid artery, middle cerebral artery, anterior cerebral artery. These are all called perforating arteries. These fill the brainstem. You're seeing a little contrast getting over to the right hemisphere. That looks really good. That's curative. Okay, that was pretty cool. Anybody holding their breath? I was. So originally I was just going to use this time just to answer questions about, there have been questions that have come up over the last few months. We have about 20 minutes left. And I'm happy to answer questions either about the case or if somebody asked about residency, about training. Originally I was going to have John on, but John unfortunately is tied up. So it's only me, unfortunately. And are there any questions? I'd be happy to answer them. How do you ensure your technique and methods never fall behind? Well, that's, you have to be aware of the technologies. You have to be aware of the changes. You read the literature. You go to conferences. Then you always have to decide, is it worth changing? You know, sometimes it's just because something's new and cool doesn't mean it's better. So we always have to hear about the data, read the reports, and then decide based on our own experience whether it's worth trying. After applying to medical school, when presented options, how do you decide what medical school to attend? I mean, I think it's kind of like choosing a college. You know, if you get into more than one, you have to go and see the culture, the location, the geography, where their medical students do their residencies. If there's something in particular that you really like to do, make sure that that's strong there. If you want to be a neurosurgeon, make sure that they have a strong neurosurgery program, because you want to have good mentors in the university hospital. So it's not so much the name, it's the location, the culture, and the make sure you have a special, that if you ever think about it, have a specialty, the research, those things matter. Do I think grit has contributed? Yeah, I mean, everything's grit, basically. Is neurosurgery stressful? I would say so. You know, we all want to be the best we can be, and so it's stressful because we're hard on ourselves, but we also recognize that there's risk of hurting people, and hurting people really is terrible. So you're always in the back of your mind balancing off those two things of the risk of hurting someone and the joy of helping someone. It's a constant balance, and that's a big challenge, and that causes some anxiety and stress for sure. Advice on combining medicine and research in medicine. You know, it depends. I mean, you can do, if you want to do bench research, like real core, like PhD level research, it's sometimes challenging to do both well. If you want to do clinical research, or what's called translational research, where you're running clinical trials, or you read the closer your research can combine with your patient care, you know, I think that's ideal. For example, I like IT research. I've been doing a lot of IT, looking at mobile applications, using mobility to communicate with patients, and you know, whether it's making movies, videos, because I can do it in my workflow, and it feeds back directly on my patient care. Well, you know, John's doing a lot more in the lab, although he's doing a little less, but he can only really spend 1 day a week in the lab, which is, you know, compared to people who are doing it all the time, it's hard to keep up. So, you know, actually managing a lab and, you know, running a clinical practice and, you know, running a department's really difficult. It's a lot, and managing that, you know, sometimes you have to give to get. You know, I've given up some things along the way because I can't do everything. You know, as you move up, you have to sometimes give up some of the things you like to do. So your junior guys and your partners they want to operate. They want to do the things they want to do. And if I try to do everything, administrate and give talks and go to meetings, then I can't possibly be as good of a doctor as they can. So I have to decide how much to do. That's hard to do sometimes, withdrawing yourself from it, admittedly. But that takes maturity, basically. How do I stay motivated and prevent burnout during undergrad and med school? Well, first of all, if you really love what you do, I don't really think you can burn out. So you make sure you're doing what you love to do. I also think staying healthy, make sure you exercise, eat right. You have to get sleep. You know, when you know, there's a whole rule in surgery: eat when you can, sleep when you can. You know, that's the basically true. I remember, you know, as much as it was painful, I'd come home at night and eat a banana in the shower was my dinner. As crazy as that sounds, I mean, you know, you just, it's like, and it's just a short period of time of your life. It's worth putting in all that effort, and it pays off. And so I think that it's just a matter, but I do think just having balance and exercise, I think, is really important. Meditation, you know, and sometimes you may need it, just talking to people when you have problems. You know, don't hold it in yourself. You talk to your other attendings, talk to the other residents, talk to their medical students. Just don't keep it to yourself, because I'm sure other people are struggling just like you. Do I have any advice for pre-med looking to gain experience in neurosurgery? Yeah, I mean, we have a summer internship you can apply to. You know, it's going to be obviously really competitive, because I'm sure a lot of you will want to come. So Randy, myself, and we'll probably use Joshua part-time, and then John and our team we can't take more than about, we probably about 8 full-time, and we'll probably do 1 week rotations just for observation next summer if COVID allows us to. But reach out, email us, get in touch with Randy. There's always ways to be creative, and maybe even come during off season if you can, instead of during the summer when there's less students around. You know, we always welcome visitors, and people who are interested in neurosurgery. Are people looked down upon whenever they attend a community college or period? No, I mean, ultimately, if you go to community college and you do really well and you transfer to a full-time university and you do well, it doesn't really make a difference. But, you know, truth be told, the sooner you get into a real university that's a four-year university, you're much more likely to get into medical school. It's hard to get into medical school from a community college. It's just that the coursework is different and the mentors are different. Obviously, you have to deal with whatever is in what you can afford and what works with your lifestyle. So, but these things are unfortunate truths. It's very, very competitive. And in order to get where you want, you have to be in the best learning environment you can be. Does majoring biology help in medical school? Not really. I mean, I majored in biology, but I wished I minored in history. I probably should have majored in history. You know, you have to fulfill the medical school requirements. You have to do all the courses over anyway. And the basic sciences in medical school don't really translate into your residency necessarily. So if you aren't perfect in your undergraduate medical school classes, it's not that big of a deal. I think you're better off enjoying undergrad and doing the courses you like and filling that in with the medical school courses rather than. And if you love biology, then be a bio major. It's no problem. It's not going to really translate into anything significant medical school unless you really take it, you do molecular biology or a research interest in biology you carry over to medical school. That can be a benefit. Someone said they're living that crazy, Jade Cornet, living that crazy life now in medical school. Yeah, medical school is great. I had more fun in medical school than I did in college, actually. I just loved it. It was just really, really terrific. Improving surgical dexterity is just practice. A lot of guys will take, or women for that matter, will take suture home, practice suturing at home, practicing tying. That's how it starts. And then you do lab courses. In neurosurgery, we have cadaver labs where we go and practice on cadavers. So practice makes perfect. This really is the 10,000 hour thing is really meaningful. Yeah, I mean, neurosurgery is kind of like an art form. In fact, it's less science and more art many of the times. Decisions are made based on gut and instinct. That may change with AI, but I think that in the end, there's an art form to it. You don't need always to do neurosurgery procedure. Yeah, I mean, for neuro IR, you don't need to do neurosurgery. You can do either radiology or neurology. It's a little shorter course. I don't think the residency training is as deep because you're not learning to operate. You don't have that experience. I don't think the intensive care component is as robust in neurology or intervention or radiology, but you can do it. Ultimately, it means joining a good, robust team, ultimately. Like right now, I'm a neurosurgeon. I've really slowed down the amount of catheter-based stuff I'm doing. Rafael Ortiz, who did that case, is a neurologist. And we have a radiologist in our group also, Dr. Cerule, who talked to you about stroke. So we have people from each of these different backgrounds, which as a team really helps. We get these different viewpoints. Everybody comes with a little bit of a different flavor, and that's good for outcome. Everybody looks at it a little bit differently. Someone's asking about neuro-oncology, Randy, how that's different from general neuro.
I think neuro-oncology, I mean, it's not neurology necessarily. It's focusing on oncology that happens to occur within the brain and spinal cord, right? But you need a good understanding of oncology because a lot of these tumors are metastatic from other regions. So typically neuro-oncologists are neurologists first, from what I find, but I've met oncologists who specialize in neuro as well.
Your questions about international medical students and Caribbean medical schools. Look, it's not fair, but it's the reality. Unfortunately, the competitive subspecialties, neurosurgery being one of them, but not the most competitive. The most competitive are probably ophthalmology, dermatology, and usually radiology. I'm not sure if that's as competitive anymore, but these here's Dr. Ortiz. We just watched you do that. Yeah, why don't you describe to them what you did? I went over the whole case while you were doing it.
So the
Slick work.
I showed them how you had the first coil in, and the second was kind of coming out a little bit. You were playing with it, and you finally got it to set.
Yeah, challenging case to be able to coil by endovascular means, mainly because of the shape of the aneurysm. We could not see the entire aneurysm in just one projection. So we had to use a lateral view to look at the origin or the neck of the aneurysm. And then we had to use the other view, the AP view, so that we could look at the distal end of the aneurysm.
Do you want to use this?
When we, you're sure?
I'll share my screen. Hold on.
You're getting a lot of congratulations here in the chat.
He was awesome. I was scared. I mean, I was
We're all watching along.
So in this
Taking breath.
view, we can see the distal end of the aneurysm. However, the neck or origin, because of the angle and shape of the aneurysm, you could not tell where the origin was because it's overlapping. And we need to be very accurate at the time of putting the coils. Otherwise, we're at risk of causing a stroke. If the coils are coming down into the normal artery, this is an anterior communicating artery that connects the left anterior cerebral artery with the right anterior cerebral artery. This is the left internal carotid artery. Then so that was a critical part to look at the neck, but this view was great for us to see this the distal end of the aneurysm, so that we could see where the aneurysm ended. The other view that we use, for some reason this is not showing great here. Okay, but the other view, the other view was better to look at the neck, at the origin of the aneurysm. So we use, initially, I put a coil trying to include the entire aneurysm. That's the usual way we coil this aneurysm. So we sized them. It measured like 7 millimeters in the maximum length. And so I used a 6 millimeter coil so that it didn't protrude into the normal artery. However, that 6 millimeter coil wasn't ideal. I had to take it out and then go in with a 4 millimeter coil to be able to secure the distal portion of the aneurysm, the end or dome of the aneurysm. And then I kept that catheter there while coiling from the bottom, and then use a 5 millimeter in the bottom, and then kept filling inside with another 4 millimeter, 3 millimeter, and 2 millimeters. So at the end of the day, it went well. The aneurysm is secured. We're keeping her on heparin, which is a blood thinner that we use by giving through the vein, intravenous blood thinner. She will remain on that overnight, just as a precaution. And then tomorrow we can stop it. And we'll see how she's doing. She had a subarachnoid hemorrhage, bleeding from the aneurysm. The treatment of the aneurysm does not treat the subarachnoid hemorrhage per se. She's going to be here in the intensive care unit at least for 2 weeks. These people are sick. They are some of the sickest patients in a hospital. And we need to make sure that we watch her so that she doesn't develop any of the complications of subarachnoid hemorrhage, like vasospasm, which is like irritation of the arteries causing cramping of the arteries that can lead to strokes. Some people develop kidney problems, respiratory problems, or cardiac arrhythmias. So we need to check for all of those in the next 2 weeks.
You're getting some compliments. Dr. Ortiz, your performance skill and pace was inspiring. Thank you for sharing. Someone needs to tell Stephen King to retire. Dr. Ortiz has presented us the best thriller we've ever seen. You know what? Someone asked a question about losing a patient. Breathtaking skill and precision, beautiful work. It was pretty beautiful. Awesome, 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 fascinating. I must say that
Thank you for the kind words, guys.
He's the best. I would not have been able to do that. I would have stopped operating the damn thing. I think that there was a question about losing a patient. Yeah. You know, that the first time we've lost a patient. I think the most important thing when it does, it's going to happen in our business. It just does. The most important thing is you're around guys that have your back. You know, the problem is very often you're in an environment where there's, I always say that the two emotions of jealousy and schadenfreude are the same emotion. jealousy, you know what jealousy is? Schadenfreude is when you're happy with somebody else's failure. It's the same emotion. People want you to fail because they want to look good, or they're jealous of your success. So the key really of any group is that you have people that are just the opposite. They're happy for your successes and they suffer with your failures. And so when you do lose a patient, the first thing I turn to is my partners. And honestly, it's not even sometimes it's the deaths that are easier to take than people you cause a stroke or cause a neurological injury. And so I think that it serves as a reminder of whenever you're going about your work in medical school, college, just, be empathetic to people, be supportive, enjoy people's success. Don't look out of the boat, be yourself, make yourself the best you can be. Who cares what the people are doing? But if somebody does something well and you hear about it, congratulate them. You don't, it's not going to make you better or make you worse if somebody else is doing well. And I think that's something you really need to start doing now, because it's really hard to change later on in life. If you're jealous and have schadenfreude for people all through college, medical school, and residency, you'll remain that way forever, and you'll be miserable. Because when you lose that patient, you're not going to have anybody to turn to, and you're going to need that so you can come back to work the next day. And honestly, if you don't have that and it doesn't bother you, that's even worse. Because there are plenty of people out there that when they have a complication, they seem not to care. And that's the last thing you want to do. What do you guys think?
No, I agree 100% with what you're saying. Yesterday, this question came up in one of my session. And it is definitely the toughest part of what we do by far. And we all remember all of those bad experiences. Sometimes we forget the great successes that we have, and when people do well and they go home and they're completely healthy after we treat them. But we all remember those very sad stories in which patients die or end up with severe complications. It is important for doctors to learn from those experiences. The bad doctor or bad surgeon is that one that has the complication and doesn't learn anything out of it. We need to think about them, every step that was taken during that surgery, and learn and review it. And then, and like David is saying, sharing it with other colleagues that are on the same boat as you. Having a strong support at home that you can really vent and talk about these things, because it's definitely the most challenging part of what we do. But at the end of the day, by far, we help more people than we hurt. And it is extremely rewarding, even when you create relationships through that moment of sorrow and sadness, because, as I said, we need to learn from it. We learn from it. We then avoid making the mistake again in the future. Yeah, it is. I don't know, Randy, what are your thoughts about this?
Yeah, I mean, everyone knows I'm fairly new to the game. This is 2 years in practice, and bad outcomes happen. At my stage in the career, I am committed to outcomes, right? That's my currency. That's how I get referrals. That's how I build a good rapport with families and other doctors. And so, do no harm, which is kind of the central tenet of being a doctor, it's my primary guidance right now. Everyone hits hard anytime something doesn't go the way it should. And like Dr. Langer said, it's amazing to have a good team behind you who can support you. The majority of people who have been in this game have had these complications before and understand it. And then what I don't know if all the students realize is, we have conferences about these things, right? We present these things to each other and we sit down and we critically analyze what went wrong or what you could have done differently. And that's, a very formalized way to learn from your mistakes. But I don't think there's anyone amongst, especially this group, who doesn't go home and just ruminate on what they could have done different or how they could have approached it differently. And I also agree with, the whole idea of focusing on yourself. You really can't be jealous of what other people are doing, and you can't let it cause you to do something that's dangerous or crazy, you got to focus on yourself and your commitment to being the best that you can be, and providing that for patients.
Yeah, I mean, it's a long process. You know, you're never really, you never get over it. If you get once you start not caring, that's when you should stop.
Yeah.
And, but then by the same token, you'd have to be really careful with the people you associate with, and make sure you understand yourself first. You don't understand yourself, that's the first thing. You have to be that person first in order to be around other people like that. If you won't have it in you to be like that, then you're going to be on your own. You may be okay, but work on yourself first, get yourself squared away, and then everything else takes care. That's really the best advice. So, well, I think you have another speaker now, right?
No, we're done. 11 o'clock. Fridays we end a little early.
Oh, okay. Well, that was great. What a great opportunity. I'm glad. I tried to slow Raphael down, but he was so dialed in. He said, "No, I'm getting going." I was like, "All right."
No, at that moment, there's a lot of stress, obviously, and a lot of intensity in taking care of that patient and making sure that we do the right thing for them. So yes, that's why we had already started.
Listen, Rafa, this is Chairman's Corner. 10 to 11. Do you understand? When you have the ruptured aneurysm, you just start at 10 and you'll be done by 11. That's the rule.
Timing on this was friggin' perfect.
It was pretty good. I timed it this way. So next week we'll have Jill Kallman on Chairman's Corner. And the last week we'll have Zach's call, which will be the last 2 weeks. We only have 2 weeks left. It's gone by really quickly. The summer's flying by. And then Randy, you know, hopefully we'll have some information about our follow-up brain internships and the satellite weeks in the spring and winter break for the students, and we'll go from there. Remember, keep pushing out your Instas and your tweets and LinkedIn. Keep using social. We love to give it back to you guys, and let's keep up the good work. I know you're all have a lot of things to do. The fact that there are almost 1,500, 1,600 people with us is really amazing. So thanks for being such great students.
Keep buying the merch. Buy the merch also, please.
Yeah, buy merchandise. Come on. We got to pay for those coils.
We got 120 free lectures. You can buy a t-shirt.
All right. See you guys.
Take care.
Yeah. Take care, everyone.